Dzień dobry, witam Państwa serdecznie. Agnieszka Rynkiewicz z tej strony i mam przyjemność wprowadzić Państwa w temat naszej prezentacji. Mówię naszej, ponieważ jest to praca zespołowa, a mianowicie w zarysie przedstawię model Autism, o którym w większych szczegółach opowie moja koleżanka dr Christine Sol. Moją zaś rolą jest przedstawić Państwu najważniejsze informacje, które dotyczą zaburzeń ze spektrum autyzmu u dziewcząt i kobiet, z ukierunkowaniem na przede wszystkim dojrzałe kobiety w spektrum autyzmu. ABC Autism mam przyjemność reprezentować Kolegium Nauk Medycznych Uniwersytetu Rzeszowskiego, który jest liderem Autism na Polskę, który jest aktualnie model wprowadzany do Polski. Więc ABC modelu Autism to to, że Autism nie jest telemedycyną, gdzie jest świadczona opieka indywidualna nad pacjentem. Jest to model telementoringu, w którym specjaliści, którzy zajmują się zaburzeniami ze spektrum autyzmu, dzielą się swoją wiedzą, uczą jak badać, jak diagnozować spektrum autyzmu, a także jak radzić sobie ze współwystępującymi problemami medycznymi, mówiąc krótko, ze współchorobowością. Więcej na temat samego projektu, samego modelu możecie Państwo przeczytać w dwóch publikacjach z tego roku. Pierwszą anglojęzyczną możecie Państwo znaleźć w Brain Sciences, drugą polskojęzyczną, do drugiej polskojęzycznej odsyłam do czasopisma Psychiatria i Psychologia Kliniczna. Tak jak powiedziałam wcześniej, moją rolą jest wprowadzić Państwa w temat zaburzeń ze spektrum autyzmu u dziewcząt i u kobiet z ukierunkowaniem na kobiety, na nasze pacjentki dorosłe. Nie sposób na temat tego dużego obszaru tematycznego w tak krótkim czasie opowiedzieć, ale na pewno zaakcentuję to, co jest najważniejsze dla tej populacji. Jak Państwo dopytujecie, Państwo klinicyści dopytujecie dorosłe kobiety, które mają oficjalnie diagnozy, to one jak jeden mąż, jak eko powtarzają, że ich potrzeby są często bardzo zaniedbywane, ich potrzeby medyczne gdzieś umykają i nie są zaspokajane, ponieważ nie ma specjalistów, nie ma odpowiedniej ilości osób, które tym tematem się zajmują i są mają w tym temacie wiedzę i są wykształcone. Na pewno, jeżeli chcemy pomagać kobietom w spektrum autyzmu, to musimy pamiętać, że one się różnią. Różnią się, jeśli chodzi o diagnozę, o to, że stosują różnego rodzaju techniki i metody kamuflażu. O współchorobowości więcej powie moja koleżanka dr Roma Wasa ze Stanów Zjednoczonych. Na pewno różnią się pacjentki, jeśli chodzi o ważne etapy w ich życiu, przez które przechodzą. Znacząco różnią się, jeśli chodzi o, mówimy tutaj okres ciąży, czy potem też macierzyństwa, ale także też okres menopauzy. I zasygnalizuję Państwu też ważne informacje, które dotyczą edukacji i zatrudnienia, jeśli chodzi o tę grupę. Tak jak wspominałam wcześniej, my już wiemy, te pacjentki różnią się, jeśli chodzi o diagnozowanie, ale my już wiemy od lat, że pacjentki te diagnozowane są później. Wynika to z tego, że nasze narzędzia diagnostyczne są niedoskonałe. I to nie tylko te narzędzia screeningowe, jak Państwo tutaj widzicie na slajdzie, czy SCQ, czy MCHAT, ale te, które my zaliczamy do złotego standardu, wystandaryzowane narzędzia takie jak ADOS-2 czy ADR. Powiedziałabym, że nawet ADR jest mniej doskonały, jeśli chodzi o wyłapywanie tych pacjentek, aniżeli ADOS-2. Wynika to z tego, że narzędzia te tworzone były głównie, albo mówiąc, żeby być bardziej poprawnym, z przeważającą ilością w grupach badanych i kontrolnych, z przeważającą ilością chłopców i mężczyzn, aniżeli dziewcząt i kobiet. Zmiany nadchodzą dlatego, że narzędzia te są udoskonalane, a także suplementowane dodatkowymi narzędziami, które pomagają w podejmowaniu decyzji diagnostycznych. Wspominałam także o tym, że że pacjentki te stosują różnego rodzaju formy kamuflażu. Kamuflaż nie jest zarezerwowany tylko i wyłącznie dla autyzmu, nie jest także zarezerwowany tylko i wyłącznie dla dziewcząt czy kobiet. Chłopcy czy mężczyźni też mogą go stosować. Jest na pewno bardziej wyczerpujący dla naszych pacjentek w spektrum autyzmu. I warto pamiętać o tym, powinni pamiętać klinicyści o tym, te osoby, które zbierają wywiad, które pracują z tymi pacjentkami, że te, które nie mają niepełnosprawności intelektualnej, potrafią opowiedzieć klinicyście, co one takiego robią, jakie formy kamuflażu stosują. Tak jak mówiłam wcześniej, na temat współchorobowości więcej opowie dr Roma Wasa. Ja na pewno zasygnalizuję tutaj to, że grupa naszych pacjentek z spektrum autyzmu jest grupą bardzo narażoną na popełnienie samobójstwa. Bądźcie Państwo bardzo wyczuleni na to. Pamiętajcie także, że te pacjentki wymagają wielospecjalistycznego podejścia. Tutaj włączani są w opiekę tych pacjentek lekarze różnych, powinni być włączani lekarze różnych specjalizacji. Zwłaszcza w okresie przedmenopauzalnym czy menopauzalnym pamiętajmy o tym, że powinni się także kształcić ginekolodzy, że takie pacjentki są. Więc to podejście wielospecjalistyczne, gdzie mamy i internistów, i ginekologów, a także lekarzy innych specjalizacji, jest ogromnie ważne. Wspominałam też wcześniej, że zasygnalizuję, co jest ważne, jeśli chodzi o zatrudnienie czy edukację. My wiemy i mamy już badania, które potwierdzają to, że wiele z tych pacjentek, które nie mają niepełnosprawności intelektualnej, może nie kończyć częściej niż mężczyźni. Może nie dokańczać swojej ścieżki edukacyjnej częściej aniżeli mężczyźni, może także rynek pracy porzucać. Więc tutaj te pacjentki dorosłe bez niepełnosprawności intelektualnej także wymagają wsparcia w tym obszarze. Mówiłam także wcześniej o tym, że jest obszar, który nadal jest traktowany jak tabu, bo on jest nadal bardzo niepoznany i my dopiero rozpoczynamy tak naprawdę szczegółowe badania tego w tym obszarze, a mianowicie okres przedmenopauzalny i menopauzalny u kobiet w spektrum autyzmu. Kobiety jeżeli Państwo wsłuchacie się lub wczytacie w komentarze, wypowiedzi w różnych badaniach, to te pacjentki sygnalizują, że ich potrzeby medyczne ogromnie są niezaspokajane, że brakuje specjalistów, i to właściwie powtarzam to, co powiedziałam już wcześniej, brakuje specjalistów. I ekoautyzm ma jedno ze swoich zadań w Polsce, że my będziemy starali się tutaj pomagać sobie nawzajem i kształcić i szkolić specjalistów różnych specjalizacji, profesjonalistów różnych specjalizacji, aby odpowiednio rozumieli potrzeby tych pacjentek. Na pewno w tym okresie menopauzalnym te pacjentki też sygnalizują o tym, jak ogromną przeszkodą dla nich jest to, z czym borykały się właściwie przez całe swoje życie, z tą nadwrażliwością sensoryczną, więc w okresie menopauzalnym to jak gdyby intensyfikuje się. Pacjentki, które mają jakąś niepełnosprawność intelektualną w okresie czy menopauzalnym, mogą stawać się jeszcze bardziej zależne od swoich opiekunów. Zazwyczaj są to członkowie rodziny. Są także sygnały pozytywne od tych pacjentek, które nie mają niepełnosprawności intelektualnej, że niektóre z nich stają się bardziej świadome swojego autyzmu, bardziej świadome swojego ciała i to odbierają jako coś, co jest pozytywne. Ograniczeniami czy ograniczenia, które nadal są, to w tym obszarze to oczywiście to, co już też mówiłam wcześniej, nadal mała ilość badań, my dopiero ten obszar zaczynamy badać, mała grupa pacjentek, ale ja liczę na to, że to będzie się w najbliższych latach zmieniać. Podsumowując temat zaburzeń ze spektrum autyzmu u dziewcząt i u kobiet, pamiętajcie Państwo, że jeśli chcemy pomagać, to musimy patrzeć na te pacjentki przez pryzmat kobiet, a także tworzyć nowe narzędzia, udoskonalać istniejące narzędzia, aby te pacjentki wyłapywać i diagnozować. A to, co chciałabym, żeby stało się jak gdyby zamknięciem mojej prezentacji i wprowadzeniem i oddaniem głosu moim koleżankom, to informacja na temat tego, co my już robimy i robić będziemy w ramach ekoautyzmu w Polsce. Na pewno będziemy pomagać, tak jak już mówiłam wcześniej, pomagać, kształcić, szkolić, jeśli chodzi o dziewczęta i o kobiety i o różnice płciowe w autyzmie. Na pewno spodziewajcie się Państwo kolejnych edycji szkoleń w wywiadzie do diagnozy autyzmu w wersji zrewidowanej ADR. Już pierwsze edycje są za nami, będą kolejne. Zapraszam na marzec następnego roku. Będziemy dalej wprowadzać program STAT, tak jak to robią też pediatrzy w Stanach Zjednoczonych i spodziewajcie się też Państwo kolejnych i publikacji, i wystąpień i naszej dalszej współpracy z kolegami i koleżankami z ECO w Stanach i w Kanadzie. Z mojej strony to wszystko. Chciałabym przekazać głos moim koleżankom, a przede wszystkim założycielce i kierowniczce dyrektorowi Autism w Stanach, dr Christine Sol. Dziękuję bardzo. Do widzenia.
Hello, my name is Kristen Soul, and I'm a pediatrician at the University of Missouri. I specialize in development, autism, and behavior. I'm also the founder and executive director of Echo Autism Communities. Today, I'm going to be sharing with you all about that program and how we're bringing it to Poland with our partners in Gdańsk and Rzeszów. First, as many of you know, autism is something that's on the rise all around the world. What we know is that autism is very common, happening in about 2% of the world's population. We also know that the current system has much of the services being provided in mostly academic centers, urban populations, and among higher income families. In the United States, we refer to this as in silos. Many places in rural communities hold their agricultural products in a silo. There's very little communication with the outside in a silo, and that's where that comes from. What we know, though, is that it's important to have more communication with other areas and other ways so that we can improve the access to care so that children and their families, and especially as they grow into adults, can have better autism care. We also know that when these children and their families, and as they grow into be adults, operate in silos, they often have increased health disparities. That can be around socioeconomic challenges, racial barriers, geographic, as well as gender. Today, we're going to talk about how a solution called Echo Autism is bridging some of the gaps that we see in these health disparities, particularly related to gender. One of the perspectives that I like to think about is that of primary care or general practitioners, those that are in specialty care that may be found in major academic centers or urban centers, and then the family. What we know is that oftentimes families are seeking answers. They want to be able to trust the healthcare professionals that they go to so that they can learn and grow and help their child or their loved one succeed and live their best lives. Unfortunately, though, many general practitioners don't have a lot of additional training in developmental disabilities like autism. That leaves many people seeking answers from specialists who are already full and have many long wait lists. So unfortunately, when you have many people having difficulties reaching the best practice care that they need, you often have people who are experiencing significantly long waits, as well as disparate care because of underlying issues like geography, where they live in rural or underserved locations, or maybe socioeconomic challenges, whatever the case may be. So when we start to think about retooling and rethinking about geographic and underserved populations having access to best practices, we can start to improve outcomes for all. When I think about autism and I think about the path forward and ways that we can start to improve equitable access to autism best practices, I like to think about a forest. Yes, of course, there are paths that many who have gone before us and who are continuing to blaze these paths are starting to lay. Maybe there are some markers that lie ahead of us, and yet at the same time, we have a lot of work to do. Today, I'm going to tell you again a little bit about something we call Echo Autism. This is a brand new program that's been going on in the United States as well as other places around the world for quite some time. But we are delighted to be bringing that to Poland so that we can share and increase the capacity to serve individuals with autism right here in your own country. ECHO is an acronym. It stands for Extension for Community Healthcare Outcomes. And at its simplest, it's about moving knowledge, not people. That may sound simple, but in reality, it really is just that simple. Oftentimes, we are asked to move patients with complexity or people who are very complex to higher levels of need or higher levels of knowledge. But what if instead of moving the people to the knowledge, we started moving the knowledge to the people? That's what ECHO is all about. And I'm going to walk you through how it works and how it's going to look in Poland under the guidance and expertise of experts in autism, psychiatry, and development right here in Poland. The ECHO model is pretty straightforward. We like to call it the A, B, C, and D of ECHO. First, A is for amplification. We use technology to leverage scarce resources. In this case, the scarce resources are knowledge about autism in women, knowledge about autism in rural or underserved populations. Maybe it's knowledge about autism best practices related to mental health conditions or suicide, various aspects that are scarce resources in many areas of our world. But the B is very important. The B in this model stands for best practices. We share best practices to reduce disparities. What we know is that best practices often live in our urban centers, in our urban academic medical centers where maybe research is being done or where new discoveries are being made. And yet it often doesn't get out into our rural communities or into our communities that are a great distance from those centers of discovery. And so that creates a disparity. And unfortunately, that means that our outcomes are weakened when we get further and further from the source of those new discoveries. So ECHO says, let's start talking about how we share those best practices and move that knowledge. We do this through case-based learning to master complexity. So the cases are actually presented by learners, not necessarily the experts, but the learners who are part of a community. And they start to continue to share their best practices and learn from each other in this case-based methodology so that we can all learn together and then monitor outcomes of our learners. This isn't necessarily outcomes of patients, but it's outcomes of learners. So can we say that general practitioners, or maybe it's psychologists or mental health clinicians, as they're continuing to learn best practices around their field, can they start to serve and meet the needs of individuals with autism in their communities like they have not in the past? Does that start to build capacity in communities throughout Poland or other locations that can now start to serve individuals in a new way, in a more efficient and more quality manner so that people can have better outcomes no matter where they live? ECHO is also founded on a principle called all teach, all learn. So sure, many of us in ECHO have expertise, particularly in autism, or again, maybe psychiatry or some additional subject matters. But that does not mean that those that come to learn with us don't have expertise. Yes, of course, we all have expertise to share, and that's what makes ECHO such a wonderful opportunity for us to learn together. We call this a learning loop where we are all coming to the table to share knowledge. I'm often sharing knowledge about autism expertise related to potentially medical conditions or psychiatric conditions from my field in pediatrics and developmental behavioral pediatrics. However, our learners have expertise in that patient as well as in their community. And that learning is incredibly important because as we're all learning, we start to magnify and amplify our opportunities for best practices to be shared across time and space and increase capacity for our patients and our loved ones out into our rural communities. One of the most important things about ECHO is also called guided practice. So that through that case-based learning, as an individual is presenting a case that maybe is in their clinical practice or often even in schools, we're doing this in a de-identified way. We're not using identifiers like names, places of employment, and things like that. We're keeping it completely de-identified so that we can all learn in a protected environment, if you will. And one of the things that's important about that is that we can then guide each other's practice. An expert can come alongside someone who has a more general knowledge base and help them to level up their practice so that they can feel more confident and in their ability to support individuals in their practice. ECHO is not telemedicine. Many of us have become very familiar with telemedicine over the course of the pandemic, but telemedicine is a direct patient care modality. And so what happens in telemedicine is that one clinician, like a physician, may see a patient through telemedicine, like a virtual means, but it does not increase capacity in communities. ECHO is different. ECHO has a hub team, like what we call a hub, and where we have experts who are coaching and mentoring spokes of learners who are all engaged in learning and increasing their understanding of an area of expertise or content that they want to learn. As their expertise grows, they are then taking that new knowledge into their practices or into their classrooms and starting to build capacity in their own areas. And so you can see how that's an amplifier and can start to really reduce disparities throughout a country or a region. What we do in ECHO Autism is we take those core ingredients of scientific discovery and accelerating our scientific discovery out into clinical practice. And we continue to work even further into advocacy and policy change. One of the things that we know about autism and disabilities is that it's incredibly important not to just stop at discovery into clinical practice, but we also have to continue to push to ensure that people with neurodiverse perspectives are able to be recognized as having value and seen for who they are and the abilities that they have. That's how we will achieve improved outcomes for all individuals with each of the different possibilities and abilities that they have and that they bring to the table. So one of the things that's important to us at ECHO Autism and ECHO Autism communities is that we imagine communities where people with all abilities can live their best lives. That's our vision, and we do that through this model that I've been sharing with you called ECHO. ECHO democratizes expertise and disseminates best practices to mentor and guide communities of clinicians, educators, and advocates, creating local expertise and increasing access for autistic people and their families. One of the things that I know, and it's important for us to all remember, is that people, both children, adolescents, and adults, are at the center of the care that we provide or the classrooms that we teach. That means that we have dignity and respect both for each other as fellow experts, but also as learners and as well as for those that we are serving. So that dignity and respect is something that we also teach and talk frequently about within our ECHO Autism sessions. We also regularly talk about co-production or working together with patients and families or students and families and experts to develop care plans and discovery together so that we can continue to advance the knowledge base that we have to serve individuals with disabilities that is about them and for them in conjunction with an expert and expert opinions. We also know that embracing curiosity is incredibly important, and it's a core value that we hold true in ECHO Autism communities. One of the things that I'm so excited about related to bringing ECHO Autism to Poland is that we have much to learn about how we can support communities in Poland and individuals with autism and individuals with autism throughout Poland and Europe as we start to think about what are the ways that we can be more supportive and or integrative of our colleagues who have autism or our patients and students who have autism. We have so much to learn. And as we embrace that curiosity, we will learn and continue to learn even more. The other thing that's important is that we continue to think about whole care for the whole person. Autistic individuals do not live in a vacuum, and I'm sure they would be the first to tell you that. They are an individual who is within the context of many things. They are in the context of a family unit, a healthcare system, an educational system, as well as a member of communities. These are important things for us to remember because as we think about this through a lens as our profession, whether we're a medical professional, whether we're an educational professional, or whatever type of profession we may be in, this individual is their own person. And so as we're thinking about the role that we play as a professional in their lives, they are a human being, first and foremost, that fits within the context of many other places. And so as we interact with them and as we build and support them to live their best lives, that's an incredibly important place that we are able to hold with and for them, but it's in their service that we are there and we are thankful to be in that place. Eco-autism is a framework by which we can build. I'm sharing with you a framework that we started with, which was around primary care or general practice. In the United States, we call that primary care pediatrics. In Europe, we often call that general practice. But the idea here was that we have very limited access to primary care, primary care pediatrics or primary care family practice that understand how to take care of a child with autism from the earliest of days when concerns first start all the way through adulthood. So we started Eco-Autism to really say, can we move expert knowledge out into our rural and underserved communities so that we can build capacity so families can get answers right where they live? This is an important component to what we do in Eco-Autism. And I'm going to walk you through how it's going to look and how we're hoping that will continue to grow and look and take its own shape as it comes to Poland and other places throughout Europe. One of the most important things, and this is a map of the state of Missouri, which is right in the middle of the United States. This is where I live, and I live right in the middle of this state. One of the things that we know is that communities are incredibly important. As communities, we know that that's where we know people best, and yet sometimes expertise isn't in each of our communities. So we started growing this concept. We were moving knowledge out from our urban centers and into our rural and underserved populations. We started with some hands-on training where we were working hand in hand with our primary care colleagues as well as our psychology colleagues to teach them skills in diagnostics as well as some additional hands-on skills that were important to helping to grow capacity in our rural and underserved locations. We've also continued to grow so that we can serve our communities better. We now have every single child in the state of Missouri, which is a population of around 6 million individuals, where we have every child within 45 miles of an Eco-Autism primary care or general practice clinician. This is a big deal because as families are seeking answers for their child, as they're looking to see who they can go to with their questions, now they don't have to go as far. Previously, they would have had to drive 2 to 3 hours to get their questions answered after having waited on a wait list. We still have a long way to go to be able to answer families' questions at the right time and in the right place. But we are building these Eco-Autism communities so that families can get those answers more quickly with the right amount of expertise right when they need it. One of the things that we know as experts is that there are many critical needs for individuals with autism. One of those is mental health. Nothing more important right now than the mental health of females with autism. Autistic women not only have significant barriers around their diagnosis, they have a significantly delayed diagnosis due to the considerable bias placed towards the predominant male definition related to autism. So it's very common that women who have autism are not diagnosed until later. And because that diagnosis is often made late, many women are faced with challenges like, why do I feel the way I feel? Why do people not understand me? And unfortunately, that triggers and often cascades into additional mental health conditions. The incidence of suicidality and suicidal ideation in women on the spectrum is significantly higher than women who are not on the spectrum. Most recent estimates estimate that 8 times higher than non-autistic females. This is a significant issue. ECHO is allowing us to consider ways that we can expand capacity, move that knowledge to where people, women, autistic women live and work and are, so that we can access them. We know that as a society, as a global society, mental health is at a pivotal crisis point. We know that the pandemic has escalated this as a significant concern for us as a global community. And we know that autistic females are at an increased risk for that. And yet we also know that our workforce is underdeveloped in this space. One of the things that we're working on with our colleagues at Gdansk and Riskdorf is that we're working on a solution to this incredibly important problem. We're working on a solution framed in ECHO Autism, where we have content experts right there in Poland who also have partners across the world who can help support the growth of ECHO Autism in Poland related to mental health and autistic females. We know that with that content expertise, we can start to shape and support and guide the practice of mental health clinicians throughout Poland, so we can create access both to screening and identification of autism in women and their mental health concerns, as well as evidence-based support for their mental health concerns. One of the things that we know is we must rise to the challenge to meet the workforce demands that we are currently facing. This is a global issue. We know that we have to do something different because there are many challenges that together we can solve and we can face. So I'm delighted and encouraged by the numbers that we have seen and participation. The numbers that you're seeing here are just from our Missouri-based ECHO at the University of Missouri. And you can see we are touching and engaging numerous people from around the world just in the ECHOs based at the University of Missouri. We also have ECHO Autism programs emanating from numerous other states in the United States, as well as about 25 other countries. So we have many, many partners engaging in ECHO Autism, the framework, to move that knowledge and get to more communities who are rural and underserved, so that we can get that scientific discovery, move that intervention out into communities, so we can get into clinical practice at the last mile or closer and closer, so that we can reduce those disparities and meet the needs of all of our populations. What we also know is that ECHO Autism is absolutely important in the professional and clinician development space. We are also actively involved in training and engaging communities, as well as a global network expansion. We also continue to explore research and discovery alongside our autistic colleagues and our autistic friends and neighbors as we start to think through how do we do things and how do we do things better. One of the things we know is that as a researcher and clinician, I don't know everything. And so partnering with people who have lived experience is vital to us continuing to grow and to learn and to get it right. ECHO Autism is very proud of the work that they do. And yet we are thankful that we have new colleagues in Poland and around the world that are going to help us continue to level up so that we can really meet the needs of people with disabilities, autism specifically. ECHO Autism Communities is a global community. What I love most, if there is one thing I can say, is that we share and we share with abandon. We don't have time to be monopolizing each other's knowledge. We are freely sharing. When we each develop something new, we share with each other. Because if I develop something new that can support a community in Poland, then I want them to have it as quickly as they can have it. Similarly, if someone in Kenya, Vietnam, Uruguay, Argentina, Chile, or Canada are developing something new that is a best practice, or they've discovered something that they know now is working in a specific population or in a different area, those are things we don't have time to waste. We have people who need us and they need us now. And so ECHO Autism Communities has a mechanism, a vehicle by which we can move those scientific discoveries into clinical practice and get that done faster, and then advocate for change so that we can improve outcomes and improve outcomes quickly. We also are dedicated to making sure that we are sharing best practices in an accessible way. So we have multiple avenues on our website that we are open to sharing, and you can share and access anytime you'd like. So these are things like expert videos that are dubbed or available in numerous languages, so that you may experience these in any language that is easiest for you to digest. This is important for us What we know is that autism is a global issue. We know that there are people everywhere that are seeking answers about their child. As a parent and as a mom myself, I know that if my child had something going on and I needed answers, I would want a place to go. Our team here at the University of Missouri and then all of our global partners are dedicated to making sure that autism best practices are accessible and equitable everywhere we can possibly get them. One avenue that we do that is through our website, and we continue to grow and expand this and welcome you to add to it as you see fit. And that's something that we continue to look forward to as Poland grows their own as well. We have extended webinar-based material as well if others want to take a longer dive into a topic, but those are important too. We also have resources, and we continue to grow these resources into other languages and multiple different topics, so that if a child is experiencing difficulties with toilet training or with anxiety or with constipation or other aspects that often go hand in hand with autism, that they aren't alone and that they have access to these things. Obviously, building up an eco-autism communities or an eco-autism program like that's coming to Poland is going to take some time. And there may be a family right here, right now that needs this information today. So these QR codes are live, and you're welcome to go to those if you want to use your camera on your phone. If you have that technology, you're welcome to scan that and go straight there. Or you can also go to the website. We do not make money off of this. We are all about sharing and sharing with abandon so that people can have access to autism best practices. We encourage you to come and learn with us. If you're listening to me today, you're welcome to come and learn. We have locations all around the world, as well as many, many topics. Today, I've focused us mostly on mental health, especially that of autistic females. And we know that that's a critical condition or critical element of what's happening in Poland. And we really want to focus in on that specifically. But what I can tell you is that there are many issues that are critical to the individuals with autism around the world today. We have everything from issues related to early diagnosis, to early access to intervention, to access to best practices in our schools, to transition to adulthood, to employment, to mental health in all of our genders, and also in thinking about the aging population. There are so many topics, but what I do know is that we have dedicated, passionate, powerful experts alongside learners who are passionate and excited to learn and grow their knowledge so that we can build that capacity and rise to meet the need. I am thrilled to be partnering with our colleagues in Poland so that we can bring this model and this innovation right to you so that you can also start to grow and build your eco-autism communities, serve your local communities so that people with autism can have and continue to live the lives that they were always meant to live. So I thank you for your time, and I look forward to additional conversations in the near future, and I'll turn it over to my colleagues for the rest of our presentation.
Welcome, and thank you all for listening to this presentation today. I'm Roma Vasa, and I work at the Kennedy Krieger Institute and Johns Hopkins University School of Medicine. My goal is to give you some highlights to draw attention to the issue of underdiagnosis of autism and co-occurring psychiatric disorders in females. Recent data from the Centers for Disease Control indicate that in the United States, autism prevalence is about 1 in 54, with a 4-to-1 male predominance. There's evidence that suggests that the prevalence of autism in girls is probably much higher than reported. And this is because girls with average to above IQ may often be missed. Recent data using 2 distinct data sets, one in a clinic-based sample and the other in a community-based sample, suggest that about 39% more girls should be diagnosed with autism, and therefore the prevalence of autism should be closer to 2.5 to 1. Autism is usually diagnosed later in females, especially if the diagnosis is made after preschool age. And there are many reasons for this under-recognition that have to do with our diagnostic criteria, measurement tools, developmental shifts in presentation, and social and contextual biases. Another reason could be that there are different clinical behavioral presentations of autism spectrum disorder in females. Females may have higher linguistic abilities, more social motivation. They might be more likely to demonstrate reciprocity, have fewer restricted repetitive behaviors and interests, and their interests are slightly different and relate to people and animals. Beneath these symptoms, though, they struggle with understanding the dance of social interactions. This milder surface level presentation may result in missed diagnoses. Another reason for the misdiagnoses could be diagnostic overshadowing, which means that the psychiatric comorbidities that are present in females overshadow the autism spectrum symptoms. I like to refer to this picture when talking about diagnostic overshadowing. You see there are two mountains. The one in the front is much darker, and the one in the back is lighter. What captures our attention is the mountain in the front, and the one in the back gets overlooked. And this resembles what's happening with diagnostic overshadowing clinically. When we see girls and are evaluating them in our clinical practice, we might be more likely to evaluate the psychiatric comorbidities such as anxiety and depression, which are front and center and very clinically impairing. Behind, though, are the autism symptoms that get overshadowed. Hence, the diagnosis gets missed. There's recent data showing that autism in females is often not diagnosed until another psychiatric comorbidity is present. And in fact, we are seeing that more severe presentations of anxiety and depression are leading to emergency department and inpatient psychiatric hospitalizations, which is the first time that an autism spectrum disorder diagnosis is suspected. When looking at the data on co-occurring psychiatric conditions in autism, we know that 40% of school-age children with autism have an anxiety disorder. 75% of autistic adults have an anxiety or depressive disorder. Some studies show that females have a higher prevalence of anxiety and depression than males, and that the clinical presentation of anxiety and depression could be different. So, for example, anxiety might manifest as anxiety about sensory sensitivities, fear of change, struggles with uncertainty, and constant social anxiety. And depressive symptoms might include loneliness, low self-esteem, focus on awareness of differences, and exhaustion due to camouflaging or masking, which refers to hiding the autism symptoms just to try to fit in with neurotypical peers. Another major concern in the field is suicidality, and this is a grave concern. We are learning that suicidality is the second largest cause of mortality in individuals with autism after heart disease. And large-scale population studies indicate that rates of suicide are 3 times higher in autistic individuals versus the general population. Suicide attempts also occur on average 3 years earlier in autistic compared to neurotypical individuals. And again, there's preliminary evidence showing higher rates of psychiatric comorbidities as well as higher rates of suicidality in females versus males with autism. So in summary, as clinicians, we need to have a high index of suspicion for autism spectrum disorder in females who present in our psychiatric practice with psychiatric comorbidities and also have co-occurring social struggles. And once a diagnosis of autism is made, it's very important to continuously evaluate for psychiatric comorbidities and to promptly intervene. And that suicide screening is recommended at every visit to prevent more severe negative outcomes. Thank you so much for listening today.
Hi, thanks for being there, and thanks to Agnès and the ECHO group for having invited me to this session. I'm Adeline, and I'm a PhD student in psychology and neurosciences in France, working on autism, but I'm also an autistic woman diagnosed in 2014. With my short presentation, relying on my personal experience, I wanted to highlight the deleterious effects of being undiagnosed and the benefits of a diagnosis. So before my diagnosis, I struggled a lot in my personal life. It was difficult for me to make close friends or to have a fulfilling romantic relationship, partly because I was too much focused on my specific interest. And additionally, I struggled a lot in my professional life as a school teacher, particularly with my sensory sensitivities and executive dysfunction as well. As I was aware that I was somehow different, I tried to hide it, which is called camouflaging and is now quite well documented. You can see there some articles related to this concept. Camouflaging allows to give good first impressions in social interaction. However, autistic persons are usually not good at camouflaging in the long run. Sooner or later, we are unable to meet social expectations and we experience social rejection. Similarly, we can try to ignore our sensory sensitivity, but it is still there, and sooner or later, we will be overwhelmed. So consequently, we experience exhaustion and often anxiety and depression as comorbidities, which in turn increase our autistic symptoms. So when I was a teacher, I was so exhausted in the evening that I couldn't even find some strength to eat. Also, I usually enjoy eating. Additionally, I did not have any social interaction except at work, as I was way too tired for that. I also had severe sleep disturbance because of anxiety and depression, which increased comorbidities as well. So basically, I tried my best to fit in, but it didn't work. And I did not understand what was defective in me. So I even had suicidal ideations because I thought it would be the only way to stop this exhaustion. Fortunately, I did not commit suicide, but went to see a psychologist and then to a psychiatrist who both told me that I have Asperger's. And this diagnosis totally changed my life, even if it took several years. As my difficulties were acknowledged, I received support and a recognition of disability for work that helped me to go back to university and change my job. I began to better understand myself and change my perspective. What I used to see as some defectuous traits turned into a variation of the norm, and I started to think that it was okay not to have many social interaction or to have rituals. It was then easier to be socially included because even if I do not always disclose my diagnosis, I can now explain who I am without being ashamed. Additionally, this inclusion was supported by changing my job to something adapted to my specificities, as I am doing research now. And I am moreover very lucky that my current job is related to my specific interests. Thus, one of my symptoms finally became a strength. My health improved a lot and I started to have more energy to interact with others. Even if I am still not a very social person, now I have good friends that I see regularly. Thus, some symptoms like social isolation are now less strong. In some, my life totally changed after my diagnosis, and I'm still the same person and still have challenges, but I have a better personal acceptance, better relationships, and a life more in accordance with my abilities. So whatever the age, I really think a diagnosis and an appropriate support can change the life of autistic women. Thanks for listening.